Uh, Good evening, everybody. A warm welcome to all of you to Sipla's program today. And today we shall be discussing an exciting new molecule, Pirfenidone. We've always been worried by scars, and we've always wondered whether we sometimes we feel so inadequate with the therapies available, and we're always looking for a better therapeutic option. So today we shall have Dr. Salim, who shall be speaking on. Can we move on to the next slide, please? Yeah. So our speaker for today is Dr. T. Salim. Sir is a senior consultant and clinical head of the Cutis Institute of Dermatology and Aesthetic Sciences in Calicut, India, and he's also an adjunct faculty in the Department of Dermatology, Kasturba Medical College, Manipal. Sir has a number of achievements to his credit. He's the board of directors at DASL 2022 to 2025, an international traveling mentor, American Society of Dermatologic Surgery. He is the current national president of the Association of Cutaneous Surgeons of India. His tenure is till the end of this year. He's had numerous other positions, including National Coordinator of IIDVL SIG Dermatosurgery. He was past president of IIDVL Kerala, organizing secretary of Dermachrome 2008, organizing chairman Axicon 2022. He's had over 300 plus invitation lectures at national and international fora and more than 40 publications. A winner of a number of awards, including President's Appreciation Award, IDVL 2016, PKH Award, ASDS International Traveling Mentorship, Nagabhushana Award in 2018. Sir's CV is so vast, and as is his experience. We would love to hear from him about Pirfenidone. Over to Sir.
Thank you very much, Dr. Josna. Thanks for that sweet introduction. So this particular talk, when Sipla wanted me to do actually, I'm a little thrilled about this particular molecule. It's because we do not have a direct topical molecule which would work on a scar. We have silicone gels, you have onion sipa extract, and various other things. None of them have a primary effect on the scars. These are all working through a secondary part, and it has been always a adjoint to various other options. And here is one molecule which do have a direct action on the scars. So let's go on to the topic. Topical Pirfenidone, unveiling a new horizon in the management of hypertrophic scars. So scars are always a challenge to both patients as well as the consultants. And we do come across scars right from basic acne scars to traumatic scars, the burn scars, the keloids, and various other hypertrophic scars. Development of hypertrophic scars and keloids are frustrating to both patients and physicians. Despite of decades of research, the pathophysiomechanism of aberrant wound healing remains incompletely understood. The therapeutic interventions for such lesions often give inconsistent and suboptimal results. That's why we do combine a lot more treatments to get optimal results. We do come across different types of scars. And the hypertrophic scars and keloids are abnormal wound response in predisposed individuals and represent a connective tissue response to trauma, inflammation, surgery, or burns. I'll first take you through the pathophysiomechanism of the scarring and the mechanism of action of this particular molecule, and further some of the literature search where Pirfenidone has been tried. The first challenge of any of the scar therapy begins with a simple identification and the diagnosis of the problematic wound healing. It can be either a keloid, it can be either a hypertrophic scar or something else. So we need to look into that, and we need to clearly demarcate whether it's a hypertrophic scar or a keloid before you take it up for any of the treatments. There are various, it's very easy to, differentiate hypertrophic scar from the keloids. We all know that. I'll just rush through that. The hypertrophic scars are usually raised red, pink, or sometimes pruritic, and they do not exceed the margins of original wound. Whereas the keloids rarely regress, and it can definitely go beyond the margins, and it keeps growing as well. Usually, the hypertrophic scars improves with time, whereas keloids usually worsens with time. Very rarely it improves. Generally, it appears within about 4 weeks after trauma, whereas the keloid may take up to 1 year or more. Which the hypertrophic scars usually occur when scars cross the joints or the skin creases at a right angle, whereas in case of keloids, it's not like that. It's usually over the areas where there are more of pressure and the tight areas like the sternal notch, the shoulders, the earlobe, etc. And hypertrophic scar, even without any treatment, after a very, very long time, it can improve over the time, or to a certain extent, it can subside as well, whereas keloids usually evolve over the time without any quiescent or regressive phase. Hypertrophic scar rarely elevate more than 4 millimeter to 5 millimeter above the skin surface, whereas usually keloids are more nodular instead. So here you see what exactly is a keloid and hypertrophic scar. Hypertrophic scar never crosses the injury line. It is always within the injury area where it heals. Whereas in case of keloid, it always keeps extending. There are various other issues as well. For example, a chest keloid with a lot of hairs. Those hairs growing through that, it can induce a lot of cysts inside, and that's why those reaction can again increase the lesions further. So again, the histopathology is also quite different. Hypertrophic scar, usually it's a primary type 3 collagen with a organized parallelly arranged collagen, whereas in keloid, it's haphazardly, randomly oriented collagen. It's usually type 1 and type 3, whereas in hypertrophic, it's scar, it's more of a type 3. So it has been recently proposed that the hypertrophic scars in keloids are the manifestations of an endothelial dysfunction during the early inflammatory stage of wound healing. So since there is an endothelial dysfunction here, this might be one of the reasons there are molecules which could work at that particular area might work over. So what we have seen is like when the injury goes below the reticular dermis, there is always a chance of hypertrophy, and most of the publication, that is around 32% to 72% of the publications have patients have shown to after burn injury to go for development of hypertrophic scar. So let's go through the pathomechanism of the abnormal wound healing. So there are patient-related factors, topography-related factors, and environmental factors. When all these things are put together, patients goes for an abnormal wound healing. So the genetics, the racial background, mostly with type 6, type 5 skin, it's more of a keloidal tendency and the hormonal disbalance. Special skin sites, especially where there is more pressure-related areas. The pre-sternal area is one of such areas. The trauma, inflammation, burn, surgery, tension, etc., which are the environmental factors, all these things put together, that can be an abnormal cellular response. The abnormal cellular response can be in two formation. It can be an increase in the growth factor production, the platelet-derived growth factor, transforming growth factor beta, the vascular endothelial growth factor. When there is an increase in growth factor production, there is increase in all this proliferation of the fibroblasts, neovascularization, increased collagen synthesis, and increased fibronectin synthesis, which is going to increase the collagen synthesis. Whereas a decrease in metalloproteinate activity is going to downregulate the collagen degradation. So the collagen is not getting degraded, whereas there is more of collagen being produced. So when this particular mechanism doesn't work, that is how you're getting a hypertrophy or a keloidal scar. So there is an increased collagen 1:3 ratio as well. So your mechanism of more collagen production and mechanism of the collagen destruction is also, hampered here. So this is the basis of the abnormal wound healing, which is leading to the hypertrophic scar of the keloid. So here it's given in a different format. So you have the extracellular matrix formation, the fibroblast to myoblast, and extracellular matrix deposition. And there is something called extracellular matrix degradation. So this part is reduced and this part is increased. So these two things put together would give you hypertrophic scars of the keloid. So it's again the keloid-prone patient, trauma, abrasion, incision, insect bite, chemical thermal burns, acne, varicella, vaccination, all these things, and healing with secondary intention. Again, in a genetically predisposed individual with the polymorphic gene coding, and overexpression of keloidal fibroblast growth factors, like whatever I have told you before. And there is also a wound tension to aggravate this. All these things put together, and a defective negative feedback of control of fibroblast differentiation, you get a keloidal tendency. So any molecule which could work in this particular pathway, that is where you have the transforming growth factor beta and so on, which would work on the inflammatory mediators, the initial part, while the healing and secondary, the TNF alpha and the interleukin pathways. So if there is something which would work in these areas, you can prevent this particular thing. So that is the basis. So as I've told you, topical treatments are usually silicone gels. As on now, what is available are the silicone gel, the silicone sheets, the onion extract gels, the pressure therapy, either with the help of a silicone or the graded compression garments. And also the procedural management, like the intralesionals, 5-fluorouracil, corticosteroids, bleomycin, botulinum toxin, the lasers and ablative procedures, the surgical revisions, Z-plasties, W-plasty, reduction in the contracture revision, all these things are being done. So we do not have any topical molecule which directly acts at the mechanism, this thing. So the preventing pathologic scarring remains undoubtedly more effective than treating it. So next to silicone-based products, the onion extracts containing products are commonly used, and we do not have anything in between or which directly works. And that is why there is a need, there's a void where we need something which would work directly on the scars. And Pirfenidone is actually something which we are looking at there. Definitely, we need to have more works from our side to say what exactly and how exactly it works. But let's go through the literature. So what is Pirfenidone? Pirfenidone is a molecule derived from pyridone, that is a 5-methyl, 1-phenyl, 2-pyridone. It is usually used as an antifibrotic agent. It has been approved as an antifibrotic agent in case of pulmonary fibrosis. It has been used in, there are various papers to show that as well. Pirfenidone's antifibrotic and anti-inflammatory effects are seen with both pulmonary and dermal fibroblasts, and there are oral preparation which is available. Topical formulations decrease scar formation without an important impact on the wound healing or infection. Pirfenidone may work to promote wound healing as well. So the mechanism of action of Pirfenidone is that I've already shown you the pathways. So here it suppresses the expression of transforming growth factor beta gene at the level of transcriptional level. It also suppresses the TNF alpha induction. That's why it is going to cut the inflammation over there. There's a dose-dependent reduction of collagen type 1 and 3 mNRA levels. And also, it affects the cascade of inflammatory and fibrotic processes. So this is how the Pirfenidone is acting on the scar. The orally available small synthetic molecule approved for the treatment of idiopathic pulmonary fibrosis. It also, so what I've told you is it has an anti-fibrotic action, anti-inflammatory action, as well as an antioxidant action. So anti-fibrotic is by reducing the accumulation of extracellular matrix and the fibrosis associated with transforming growth factor beta and platelet-derived growth factor, etc. And the anti-inflammatory action by action on the TNF alpha, interleukin 6 and interleukin 1 beta, and an antioxidant action by where it scavenges the oxidative species, neutralizing the hydroxyl and the radicals, etc. So all these three mechanisms other. So this explains what exactly I've told you. So it works in this particular area where the interleukin 6 and the inflammatory part, it works here. So again, here also it shows that inflammation being worked here. It also works on the transforming growth factor beta, and also the conversion of fibroblasts to the myofibroblasts. It inhibits that part as well. So this is how it works in a nutshell. So let's go to the publication evidence on topical pirfenidone. So topical pirfenidone in the in vitro. Let's go to the in vitro data first and then go to the in vivo data. So these are some of the papers which shows that pirfenidone has a direct action in reducing the pro-fibrotic response in human dermal myofibroblasts, as well as it also has attained a pro-fibrotic contractile phenotype differentiation in human dermal myofibroblasts. In vitro results proved that this is a promising anti-fibrotic agent for prophylaxis and the treatment of existing scars. There is one more paper which showed that pirfenidone treatment modulated the inflammatory response of the burns wound. Again, this is an in vitro study, and further studies can validate the use of pirfenidone for prophylactic treatment to improve long-term outcome of scarring and contracture in deep partial thickness burn scars. Yet another study which was done in the burns pediatric burns unit. This was again a controlled study where you have around 63 pediatric patients with severe hypertrophic scar were used, included in the study. In the study group, there were 33 and control group 30. In the study group, they applied pirfenidone 8% gel 3 times a day for 6 months, whereas in the control group, it was a pressure therapy. So one was with the pressure, one was with the pirfenidone. And this was there was no, the safety wise, it was very safe. No serious adverse effects were seen. It did not induce any abnormal variation in the laboratory parameters as well. So these were the results from the study. There was excellent results with this is actually a monotherapy study. Topical administration of 8% pirfenidone gel 3 times a day is more effective and safe in the treatment of hypertrophic scar caused by burns in children as compared with the standard pressure therapy. So one-to-one study on pressure versus pirfenidone was actually pirfenidone scored a little better than the pressure therapy. So if you could combine both, maybe that might be the way what we treat most of our cases. These are a few other studies. The first study is like co-adjuvant treatment with surgery and pirfenidone in severe facial trauma due to the dog bite. And they found that the severe facial dog bites represented a safe and effective therapeutic option and protected improving patients' quality of life and minimizing long-term sequelae when pirfenidone was applied immediately after once the wounds started healing. Another study is on the scleroderma, and the scleroderma, they found that there is considerable effectiveness and good safety profile with the advantage of topical application of pirfenidone gel in treatment option of localized scleroderma. The third study is on the chronic diabetic foot and the ulcer management. In addition, the addition of topical pirfenidone in the conventional management showed significant improvement in the healing of the chronic diabetic non-infected foot ulcers. So definitely they do have a role on normalization and reepithelialization with normal fibroblasts in case of chronic non-healing ulcers as well. So this is from the same study. What they have found is like within about 16 weeks, the ulcer has completely healed. These were non-infected diabetic ulcer, which was not improving, but they have combined with a pirfenidone gel. And this is the study on the and the scleroderma. They found that there have been improvement in the scleroderma skin severity index and the histopathological as well. So considering the effectiveness of the good and safety profile and the advantage of topical application of Pirfenidone gel can be used as a treatment option for localized scleroderma. So biopsy also showed that there was improvement. This is also from the same study. They found that the plaques with erythema and peeling and fissures improved drastically. And this is the histopathological study, which the part which is shown in the same study. They have shown that there is definitely an improvement and the matured fibroblast deposition and rest of the appendages in the treated area. So there have been not much of issues with the side effects profile. Basically, this is one of the studies, the Indian part which is being done. Primarily, there is it's non-irritating. This is hypoallergic. There's no photoirritation or comedogenicity with this particular molecule. So to conclude, I would say that definitely we do have some hope in this particular molecule. This is a novel treatment option for hypertrophic scar because we never had anything. Let us work on this, and the most of the studies and most of the literature say that it is a promising drug, and the potential to prevent the formation of the scar, also to improve the appearance of the scar. So basically, immediately on a burn scar or any other scar in a hypertrophic scar, if you could start using as early as possible, definitely it also acts as a prophylactic agent as well. I feel that it's worth exploring. So thank you very much. Thank you.
Thank you, sir, for that wonderful talk. And yes, so now we do have a lot of questions here. And so what do you feel, sir? What is your overall opinion about this molecule?
See, theoretically, definitely there is a role for that, for sure. We have been using for maybe last 3 months, 2.5 to 3 months, I think. Since we have started using, many of my patients are on this particular thing, because definitely it can be an adjunct to many of your regular procedures and regular treatment part. So if there is a patient who is coming with a burn scar early phases, my primary thing would be to start them on a silicone-based gel along with a pressure bandage part. So definitely there, if you could have one more molecule which could be applied. So definitely this is one thing. It has definitely a role in the prophylactic part, as well as it can also be used as a treatment part in even scars which has been for a very long time as well.
I think what I liked about Pirfenidone, the picture, whatever they've shown us, that it doesn't seem to be showing much irritation when applied on a broken skin surface. Whereas most of the gel-based scar creams which are there, the silicone-based and all, we're not able to use them on broken surfaces. So that at least from what you've presented, it looks like we could use it even as soon as the wound occurs. So how early would you like to start it?
For a scar, definitely I would start it immediately after reepithelializations happen. But there are studies where they have used in chronic non-healing ulcers.
Exactly.
So definitely we can also try it if there is no infection, if already the infections are gone, if it's only minimal reepithelialization which is going to happen, also you can definitely use it. And definitely exactly. we need time. If you ask me after 1 year, definitely I would be in a better position to tell you how it
Agreed. No, that was the only one point which I felt which is kind of distinguishing it from other scar creams, is that typically when we try using silicone gels on broken skin, they do tend to cause irritation. So here, since the studies have shown that they were used on broken skin, they showed a non-healing ulcer and which has apparently healed. So which means maybe it won't cause that much irritation. So there are a lot of questions here. We could just run through them one by one. How good is the transcutaneous absorption of Pirfenidone?
Definitely, it is the as on now, it is all the available. If this molecule was topically available in South America, for a little while actually. So basically, there are few reports on those particular part. So
Yes,
the absorption is good to the if even if it is a thicker keloidal scar or hypertrophic scar. Second thing is
yes,
like it is very safe in pediatric age group as well. There have been studies on basically there are comparison studies on pediatric burns patients as well. So and it's
exactly.
non-irritating. So even if you it's worth a trial definitely even in the pediatric population.
Do you think we can combine it with like the way when we use pressure garments? So similarly, can we combine topical
Yes.
pirfenidone with other modalities?
Yes, definitely. Scars means combination treatments. We usually don't go for any
Exactly.
monotherapy. So definitely there is a role for that. And
Yeah,
in a pediatric patient where you cannot combine a pressure or something in a very small kids, there definitely applying something is better than applying nothing.
agreed, agreed. And well, it seems to have opened a Pandora's box regarding scars because we there is a flurry of questions out here. So, well, there are questions like, can we use it in stretch marks?
We can
Stretch
actually
marks, acne scars.
we can try it out. There are no reported studies where they have shown in the because all as far as which I have searched, I have never come across any study on a stretch mark anyway.
Yeah,
Definitely, we can think about it and let us see how it works.
yeah. The only thing is stretch marks may not have that much of fibrosis. It's
Exactly,
so that's the
it's more of
one
a
thing.
trophy.
Yeah. Okay. So, uh, well, somebody wants to know if it would work in venous ulcers,
Ulcers it works.
neuropathic
So why?
ulcers.
Yeah, ulcers
We could,
definitely. Diabetic ulcers are actually arterial ulcer sort of a stuff. I mean, there is
yeah,
yeah. So definitely we can try it out in any sort of an ulcer where there is no infection. And if you're looking for reepithelialization, definitely we can. We should try it out.
absolutely. And what is your view? You already talked about keloid, but I think it's very promising on its use in keloids.
I think that
Uh,
it is primarily indicated for hypertrophic scars. Okay,
exactly.
it's primarily the molecule is for hypertrophic scars. We need to work on early keloidal part as well, but I don't
Yes.
know how far it will work.
Yeah. And do you think any contraindications for using this?
So for topical, this thing, it has not shown any allergic reaction, any photosensitivity, any comedogenic activity. So nothing. It's almost very bland, if I say. I mean, in terms
Exactly.
of irritation and things. So I think there is no primarily any no, there is no primary contraindication for any of the topical applications.
Mm. So, you think any age restrictions in pediatric patients? I mean,
So so far no
maybe
basic. Yeah, basically
I,
even in the study which I quoted that it was done even the what do you call the inclusion criteria, they were very young children. So I don't think we do have much restriction on over there.
Yeah. Now, it does have a decent percutaneous absorption. Systemic absorption, like, would body surface area be a concern when we apply? I think should we have some limit, maybe this much surface area scarring? Because those pediatric dermatology slides, those
Yes.
burn scars, were
Hmm.
pretty extensive where they had used it.
Yes. So the systemic part we need to look into. There is
Hmm.
no major systemic side effects with the oral preparation as well. So
Yeah.
definitely we need to look into how much would be the largest area which could be applied and things like that. We need to get in. I mean, look into that part. I'm not really aware of. I mean,
Hmm.
how far you could go, sort of.
Yeah. And they have mentioned 3 times a day daily application. Would this apply to ulcers as well, or
No,
should we
ulcers you
maybe
can.
try
Yeah, ulcers you can
using it
definitely do a
less?
dressing
Hmm.
because it is there actually. Whereas when you apply it
Yes,
over a surface area, it gets absorbed and after time it's not there. Whereas you're keeping the gel there and you're putting a like a dressing over there. So you need it whenever you do a dressing, you dress it better.
agreed. Fair enough. I think we have covered most of the questions. Is it effective in keloid and morphia? Well, time will tell. Like,
Yes.
it's still, it should work. There was a study which mentioned it.
Yeah. Localized
And
scleroderma, definitely they have studies
yeah.
for that.
And when can we start using? I think immediately, or matlab, if once there's no active infection, we could start. Mm, okay. Somebody has also asked about trophic ulcer in Hansen's disease. Can we use it over there? Or in a neuropathic ulcer? I think we can
Okay.
combine it with PRF. Uh, no contraindications, body surface area, 3 times. So I think we've covered most of the questions. So, so, and so far, well, it's still a new molecule. So, any cutaneous reactions, it's a little too early to comment, sir. But in the
Hmm.
last 3 months that you've been using it, have you not really noticed any
Nothing, nothing.
problems,
Not
right?
even one single patient has come up with this.
Yeah.
And they were, in fact, they had issues with other molecules which I have prescribed to them, actually.
Exactly. In fact, that's precisely why I asked you about whether we can use it on broken skin or not, because that many times is a concern when we are using gel-based anti-scar preparations. Um, okay. And age restrictions, I guess, maybe 2 to 3 years
Yes, there is
onward.
yeah, in fact, there is not much of a age restriction. So definitely, maybe after 2 to 3 years, you should be, because even the burn scars study also had very young children.
Yeah. Okay. So it's very exciting to have a new molecule here, and every as our options for a scar, which is can real, as you said, the first slide which you put in your presentation, a scar is a scar is a scar, period. So if we can do whatever we do to make it better, would definitely make life nicer for our patients and increase their face value as well. So it was a good presentation. I think we are done with it. Should we?
Thank you very much.
Yeah, thank you, sir. What do you say, Priya? Do we call it a day or do we hang on for some more time?
I think we are done with almost all the questions. There's one more question. I think
Uh-huh.
effect. Just
Nothing. The major side effects on normal adjoining skins, right? I don't think
Yes.
there is anything so far. There is nothing to, even the in vitro studies and the in vivo studies have not shown anything. Even the challenge tests with the Indian study also did not reveal any such effects.
And in fact, Pirfenidone was used orally to treat idiopathic pulmonary fibrosis, and then it was extrapolated to skin. So I think that is the story of most dermal therapy. They start and serendipitously it ends up on skin, like minoxidil.
Yes.
I think there are no other questions. One question that, sir, it is on the acne scars.
Hypertrophic acne scars, definitely you try it.
Yes, why not?
Yeah. Okay. Very good evening, everyone. I am Priya Pujari from Cipla's Medical Affairs team. On behalf of the entire team of Cipla Externa, I would like to extend a heartfelt gratitude to all of you for joining us today in this insightful and engaging webinar. Firstly, a special thank you to our distinguished speaker, Dr. Salim, sir, for sharing your valuable expertise and perspectives on topical pirfenidone. Your in-depth knowledge have certainly deepened our understanding and provided us with your valuable takeaways. We would also like to extend a sincere gratitude to Dr. Josna Dev ma'am for our esteemed chairperson for graciously moderating today's session. Your guidance and thoughtful facilitation ensured that the discussion went smooth and engaging, and this helped us explore every aspect of the topic. Lastly, a big thank you to all the doctors who participated today. Your engagement and thoughtful questions throughout the session has made this webinar even more meaningful. At Cipla, we are committed to supporting the medical community with latest information and innovative solutions. And hosting such webinars is part of our ongoing efforts to share knowledge and foster collaborations. We hope that you found today's discussion valuable and that it will contribute to enhancing your practice and patient care. Once again, thank you all for joining us today, and we look forward to future opportunities to connect and learn together. Good night, everyone.
Yes. Thank you.
Thank
Yeah.
you.
Thank you, doctors. Thank you very much for your